Perfect.
Yay, let's see how this goes. Okay, so extended release buprenorphine. And now I gotta figure out how to dance. Great. Okay. So I'm going to start just by a super brief review of buprenorphine generally, not in an extended release or pill form, but just what is bup. And just as a reminder, we have really three kinds of pharmacotherapies for opioid use disorder. We have antagonists, and what those are medications that block opioids. And if you look at this figure, antagonists would be on the bottom line. So the drug dose is on the horizontal and the effect on the opioid receptor is the vertical. And an antagonist, you can keep giving the medication, and the more you give, you never activate the receptor. It just blocks the receptor. So if somebody takes an opioid, it can't get to the receptor. So an antagonist would be like Narcan, which we use to reverse opioids, or naltrexone like Vivitrol, which we use for opioid use disorder. Somebody takes an opioid, they can't feel the effect. The top line is the full agonist. So those are medications that sit on the opioid receptor and activate it fully. So that would be, if you're talking illicit, that would be, for instance, heroin. So it sits on the receptor, it activates it fully, you get some euphoria, you take away the pain, etc. If we're talking about medications for opioid use disorder, that would be methadone. It also sits on the receptor, it activates it fully, but it lasts a really long time. You don't have the ups and downs of craving and withdrawal, and it is very effective. Buprenorphine, also known as Suboxone or Sublocade, or Subutex, is the middle one. It's a partial agonist. It sits on the receptor and it only activates it partially. So it'll take away craving, it'll take away withdrawal, but it won't give the same euphoria. And also, so going back to the full agonist, if you look at methadone or heroin or morphine, any of the full agonists, the more we give on the right, on the horizontal, the higher the dose, the higher the effect. The higher the dose, the higher the effect. The higher the dose, the higher the effect, until you get to that top line where it flattens, and that's really death. So basically, you can continue to take it and get more and more effect until you die. With buprenorphine, the middle line, if you look, the more you take, again, that dose is on the horizontal, the greater the effect for a while, and then it plateaus earlier, but that plateau isn't death. That plateau is just no more effect in terms of craving or withdrawal. So it's very, very, very hard to overdose on buprenorphine. It's an extraordinarily safe medication. So those are our three types. We've got naltrexone, the antagonist, buprenorphine, the partial agonist, and the full agonist, methadone. And we are going to be talking about bup today. The form that we're most familiar with are the pills, or also the films. And just to remind everybody why this is such an important medication for us all, first of all, we know it decreases opioid use. This is one trial. There are many trials, a multi-site trial of buprenorphine naloxone for 653 opioid-dependent patients at 10 different clinics. And they put some on buprenorphine detox. So basically, let's get you off your oxycodone, we'll get you on bup, we'll taper it off and you'll be done. They put some on it and kept them on it as like a chronic disease med. People who got detox with buprenorphine really returned to use as soon as the buprenorphine was finished. Those who were kept on buprenorphine, so on maintenance, about 50% were still not using illicit opioids at the end. So it was very effective, and success being minimal or no use. So it decreases opioid use, period. It also increases retention in treatment. So again, this is a trial looking at people who were put on bup to get off heroin or they're prescribed opioids that they weren't using correctly or whatever, or they were kept on it. The green line are people who were detoxed using buprenorphine, and basically 0% remained in treatment by the end of the trial. Those in maintenance, about almost all of them remained in treatment, and 75% were not using illicit medication, illicit drugs by the end of the trial. And more importantly, there were no deaths in the maintenance group, and 20% of those who were detoxed using bupe were dead by the end of the trial. So it's also life-saving, which is the most important thing. This is a figure, a meta-analysis looking at all at mortality risk during and after buprenorphine treatment. And if you look at the left, that's all-cause mortality for people with opioid use disorder. The risk of dying on bupe is blue, off bupe is orange. So you can see that being on buprenorphine decreases people with opioid use disorder, their risk of dying by more than half from any cause. So it just makes it less likely that they will die, period. On the right is overdose mortality. It has an even more remarkable effect in terms of dying from overdose. So it is an absolutely life-saving medication, in addition to keeping people in treatment and in addition to decreasing illicit drug use. So it's awesome. So if it's so great, and with these pills and these films, why do we need a shot? Like, what's the deal? So the promise of long-acting medications. First, it improves adherence. It's for any medication, we forget to take them, or we don't want to take them. So if you have a shot that lasts 4 weeks, for instance, like Sublocade, you don't have to remember to take it. So you've got it, it's done. That shot lasts for 4 weeks. It does decrease diversion or misuse. There are robust conversations, I think, to be had around diversion and the harms or non-harms of diversion. But there are certainly harms of diversion, and there's the risk of kids getting into pills and et cetera. And if it's a shot that lasts 4 weeks, it is not diverted, period. And if we know that being on buprenorphine increases treatment retention, then having buprenorphine in your system for 4 weeks, we don't have studies on this, I'll just say that, but it's sort of the logical next step. It is going to increase treatment retention. That I know of, we don't have studies on this. And similarly, it's going to decrease the adverse consequences of drug use. We know that buprenorphine, pill and film, decreases overdose and keeps people alive. So if you have it in your body for 4 weeks, your mortality risk is decreased for those 4 weeks. Again, period. It's there in your body. It's much, much, much harder to overdose with buprenorphine in your system. Okay, so that's why a shot, even though the pills are really good. There are 2 types of extended release buprenorphine. Only one, which is Sublocade, is approved in the United States. The other, CAM 2038, also known as Brixadi, is not yet approved in the US. Sublocade was approved in November 2007, and sort of the big study that came after it was approved was a randomized control trial of 3 groups. One group got 6 injections of 300 milligrams. One group got 2 injections of 300 and then 4 of 100. And then the other group got placebo. And this is the results. If you look on the left, percent negative abstinence, percent negative UDS by self-report. Red is the 300 milligram group. Purple is the 300 plus 100 group. And they all basically had about 40% negative UDS by self-report, negative UDS and self-report. So about the same results. Placebo had about 5% negative urine drug screen results. So really good results and pretty much the same for both dosing regimens. Also, if you look at retention, same shtick, red and purple are the shots, whether 300 or 300, 100, and blue is the placebo shot. So very effective, and the 2 dosing regimens were about equally effective. I'm missing a slide. Oh, there. And then I think one of the really interesting things is they've also studied patient-centered outcomes, for which we, particularly in substance use disorder treatment and research, we're so concerned with urine. And so it's really nice to see a study that isn't just about what did the urine show, but really how did how are people doing generally in their lives? And so Ling measured patient-centered outcomes, including physical and mental health measures, which improved significantly on Sublocade, increased employment, increased medication satisfaction, and decreased healthcare utilization for patients on Sublocade. So it just very effective on multiple fronts. And this is just one of the figures from the study. Again, it was placebo. It was the same cohorts. So red is not satisfied, green is super satisfied. The placebo had more red and neutral than green. The 300, 100 and 300, 300 had just super green. They were very satisfied and extremely satisfied with the medication. Okay, so that's the why and the results. So what's the process? This is just like the nitty gritty. So first of all, you have to refrigerate it, but not at like Pfizer COVID vaccine kind of refrigeration, just like refrigerator. You don't need to have it out for a long period of time, but it does need about 15 minutes to get to room temperature. And then once it's at room temperature, you have to use it within 7 days or get rid of it. So Vivitrol, for instance, you can take it out, put it back in, take it out. I think you can take Vivitrol, it's like 7 times or something. I can't remember, but Sublocade, it's once. The recommendation, or I guess it's not just the recommendation, you're supposed to put somebody on Sublocade, on sublingual buprenorphine for 7 days before starting it. I will say, I know some providers, including myself, who have not had somebody on sublingual buprenorphine for 7 days before starting it. I've had them on buprenorphine, and then if they, for instance, in the hospital, and then I know they're leaving the hospital and they've only been on bupe for 3 days, I'll just start the Sublocade. I think, and I don't know this, that one of the reasons for the 7 days is just to make sure that they can tolerate the dose, because there's no adjusting the dose once it's in there. So if somebody doesn't need at least 8 milligrams, probably the dose of Sublocade is going to be too high for them. So if you start them, they're on their sublingual bupe for 7 days and they never go above 8 or they only need 6, probably don't start the sublingual bupe. The Sublocade. The first bupe dose, I wrote this wrong, but so basically the Sublocade should be administered about 24 hours after the last sublingual dose. It's fine if it's not. If it's a closer interval, that's fine, but it's recommended about 24 hours after the last dose. So you could do it like if you have a patient who took their sublingual bupe that morning and they come into clinic that afternoon, it's okay to give them the Sublocade. Most patients start at the 300 milligram doses for the first 2 months, and that's like a loading dose. It elevates the plasma level, and then they can transition to the 100s. Some patients, so most patients are going to just go to those 100s. Some patients don't, they do need a higher dose. And generally you will know that if they're on their 300 dose and they're still saying, I still crave, I'm still like not feeling right, or you even need to give them some little extra sublingual doses, then you probably wouldn't transition them down to the 100. Or you transition them down to the 100 and they say, I can really feel it. I'm really craving now. Then take them back up to 300. There's no danger in that. The interval is not super, you don't have to be, super compulsive about it. So you can give your subsequent dose about 2 days ahead of the scheduled dose. So you've got your 28-day interval. So if it's day 26, that's fine. And I think this is what's really exciting. One of the really exciting things, and Jonathan and I learned this with Jonathan seeing a patient who had it was when we first started using Sublocade, and the guy had just kind of not shown up for quite a while, and he came back and I didn't know what to do. Like, do I have to, it had been, I think about 6 weeks, and I didn't know whether I needed to induce him again or sort of what to do, but you don't, it's nice, it hangs out. So if they miss that 28-day mark and they come back in 42 days later, it's fine. Just give them another shot. And again, you can give supplement, particularly after that first injection. people sometimes are still craving while they're adjusting, and you can give them some additional sublingual. The other, I think, really great thing is that it does taper off. So that's one of the reasons why you can wait. You know, if they don't show up, you can still give them the next injection, not super tightly controlled. But also, if somebody wants to stop, it's tapering off slowly. So they're not going to feel like, you know, on day 29 or day 35, suddenly sick. It self-tapers, which I think is really interesting and hopeful for people. And concentration levels remain at therapeutic levels for 2 to 5 months on average. So really, it sticks around. And after achieving steady state, patients discontinuing Sublocade may have detectable plasma levels of bupe for 12 months or longer. So not only are they not feeling craving or withdrawal, but they're also less likely to die during that period. Big deal. So sounds awesome. What's the downside? Well, one is the needle gauge. So that CAM 2038 I was telling you about, that's not approved in the US, has a 23 gauge needle, which is kind of like the flu shot needle, a nice skinny needle. Vivitrol, for those of you who have used it, you know it's a little bit bigger needle. It's 20 gauge. Standard release bupe is a 19 gauge needle, so it's a bigger needle, and it's subcutaneous, and it's in the belly. So it hurts. It really hurts. And it's not just the big needle, actually. I think it's also, patients tell me it's, you know, it goes in like a ball, kind of. It's this ball that dissipates. And they say just that, I don't know, I guess that weird feeling of expansion, it just hurts. It just, even if you put lidocaine, the whole shebang, it just hurts. And so maybe the other downside is that it's not CAM 238 because, or 2038, because CAM 2038 has this skinny needle, and I have never used it. It's not approved, but we have a colleague who has, who says that it's much more tolerable. It also comes in weekly and monthly formulations. So I think it's a more flexible and less painful medication. My understanding is that the reason it's not approved is drug company battles. It's not that it, you know, it's not anything about its effectiveness. It's also super expensive. That's the other downside, as Jonathan alluded to at the start, and getting it insurance to approve it can be quite difficult. And that's all I've got. Any questions?